whole person? This is a question and thought that has come up a lot in my practice because I will be talking to clinicians, much like yourself, probably a lot of people here. And the question I will inevitably get is okay, this gene, this is telling me one little piece of the person, but what's the big picture? How do I use this to treat the whole person? Because that's what we're all about, right? We're about treating the entire person as they are sitting in front of us. And genetic testing can be just like one glimpse of one aspect of them. So my goal is to tie genetic testing into your everyday practice and to help you and give you suggestions on how to use it to treat the whole person. So learning objections are right along that same idea. So I want to increase your ability to interpret somebody's genotype. So when you get that test in front of you, so you can look at it as a whole and then incorporate it and help it or use it to help explain what you're seeing in front of you. Also, I like to help identify some symptoms that might cue you as a healthcare practitioner into ordering genetic testing. I get that question a lot, like when should I know when to order a test? So we're going to talk about some symptoms that might kind of like increase your desire to order that test. Also, help explain the identifying and, we're going to talk we talked already a lot about research, so I'm going to tie that into how research affects which tests you would want to order. And mainly what that means is you really only want to test medically relevant genes. You don't want to order a test for a gene that has had one study on it and could potentially scare your patient unnecessarily. Also, I want to talk about disease kind of clusters, genes that are all associated with some pathway in a certain specific gene. An example would be weight management. So I want to talk about a lot of the main genes that have been shown to be related to obesity. They have a lot in common, and they can sometimes interact. And that's the last thing is I want to talk about gene interactions. One, we have some genes we have several genes that we test for example, that have to do with vitamin D levels. They're affecting different pathways within, within that vitamin D pathway, transportation, metabolism. But if you have genes or defects in a lot of these genes, then you're going to have an even higher chance of struggling with maintaining a healthy vitamin D level. So we're going to talk about associations. So the quote of the day, the most profound change that genetics brings about might not be scientific at all. It might be mental and even spiritual enrichment, a more expansive sense of who we are as humans, exponentially, and where we came from and how we fit with others' life on Earth. And so it's a bigger picture. That's my goal with this quote, is for you guys to just see genes not as this one tiny little unit, but look at it as in the frame of a bigger picture. So I'm going to discuss some scenarios that I've encountered working with giving genetic test results to a patient. And one of the ones is that a patient will say, well, I see that this is my genotype, but this is not my phenotype. This is not my symptoms at all. This doesn't explain me. And really what it comes down to, again, is coming back to that treating the whole person. Genes, if you take home nothing else from this lecture, I want you to take home this. They are increased risks for development of certain conditions. They don't always mean that you are going to 100% develop this condition. And that's a lot of the problems that direct-to-consumer genetic testing companies are running into. They're giving their test results, giving patients test results directly to the patient, and they're not understanding that key. That's getting lost, that explanation. So we also want to help you understand, again, those gene interactions, what it means to take the genotype and look at it as the phenotype, and looking at the whole symptom picture when analyzing the genetic testing. And then we're going to touch on how to choose the best treatment plan for that individual. Because really what it is genetic testing should be help helping you individualize your treatment plans. That's our goal for today and for all the tests that you order. So here's an example of a conversation with a patient is what I say, but this is a situation where we have a 48-year-old female who she wants to know her genetics. Her test results were that she had several risk alleles for genes that were involved in weight management, a lot in appetite regulation. But she reports that she has a normal appetite and that she's been thin her entire life. And I think to myself, wow, because I'll get these test results come across my desk and I'll start to form opinions about the people before I meet them. Like, this person is hungry all the time, right? And so then I'm like eager to meet them to see if I'm right. And she says to me, no, and I see her and no, she's very thin and she's been thin her whole life. But then as I dig a little bit more, both her parents were really obese. And she has since an early age been compensating for that, exercising a lot, eating a really good diet, high in fiber, very fastidious about her weight. And then you start to think, okay, yeah, obviously these genes that deal with increased appetite she's already compensating for that before we even came in and started this conversation. A lot of the treatment recommendations that I make for people with this genotype, she's been doing since she was a teenager. So that's one of those things where you have your genotype and then you have your phenotype. And you really got to take the symptom picture into play when analyzing these test results. So here we are, fruits and vegetables. I had so much fun coming up with pictures for these lectures. I almost don't tell Dr. Kashi, but I think I spent just as much time selecting pictures for this presentation. Right? Here's another one. So I have a patient, she's about 41-year-old female, struggled with her weight her entire life. We're sitting down, we're going through her test results. Again, she has several genetic markers for obesity, ones that deal with, and we'll talk about these individually and dive into them, but ones that deal with increased calories, fat absorption, so she's getting more fat from her diet, she's having a harder time breaking down her sugars, she's craving food all the time. She's like, yes, I've been trying to lose weight, I cannot lose weight, I exercise, I eat right, I cannot lose weight. And we're talking about how she can use these genetic test results to improve her outcome. And then at the very end of the visit, she says, oh, and does it matter that I have I had my thyroid removed and I have no gallbladder? So I'm like, yeah, for weight loss, that does matter. And that's one of these things, like I get into these consultations and I jump in and not me. I should really be taking this full history first and going through it first before, talking about weight loss. And these things matter. So sometimes you can have no genes that are at risk, but still have obesity because of a lot of different things. I was raised on macaroni and cheese, so to speak. I actually was. So, always looking at the bigger picture and always taking a thorough history, which I don't need to tell you guys that, but it is an example. So again, a patient, 27-year-old male with a history of depression, anxiety, sleep disturbances. I thought for sure he was going to come back with some issues in the COMP gene, which has a lot to do with dopamine levels, some issues with MTHFR, something, right? Nothing, right? Well, but that's another thing. Like, we're looking at it from a whole other angle. Depression, anxiety is a complex condition with a multitude of causes. It could have been just that he had some, a serious event in his life that traumatized him, that set him off. Or it could be some other gene or other neurotransmitter dysregulation. Or it could be that he has a leaky gut and he's not getting any, amino acids to make these neurotransmitters. So this is not the end all to the be all. And I know I don't need to say this, but I'm going to. The human body is so complex. Medicine is so complex. So this is one piece. So what are some of the most common symptoms that appear to be associated with specific risk alleles? I'm going to go through and I want to talk about symptom pictures and kind of like, not red flags, but things that I would say if I had a patient start to describe to me, I'd think, oh, genetic testing is right for you. So genetic testing in the cardiovascular system. a lot of the genes with the cardiovascular system are, and I really like Dr. Kashi, I love when you were saying like the best physician prevents disease. A lot of genetic testing is absolutely fantastic for prevention. And I would say one of the number one times you would order it is when you're going through somebody's history and they start talking about their parents and their grandparents and that kind of stuff. That's when you're going to say like, oh, your father had a heart attack in his 40s or his 50s. You know, these are things you would think to order blood work, right? But now you have this whole other level of genetic testing at your disposal, which is absolutely fantastic. But some other things, there's like, if you have a patient and you're trying to bring down their blood pressure and you're going through all the normal things and they're just not responding like a normal patient would, then you can think there are genetic defects in your ability to produce and make nitric oxide to relax those blood vessels. So these are some of the things that you could, if you see this, you would order genetic testing. Cardiovascular disease in a patient without any risk factors, number one, age. If I hear somebody say, I have this patient with really high blood pressure and they're young, they're in their 20s and 30s and they don't have, you know, maybe they're not smoking cigarettes or doing some of these other risk factors that would increase their blood pressure, like maybe they're not overweight, then you would think this could be a genetic cause. Because I have patients all the time that say, I don't know my father's history or I don't know my mother's history, so you can't always rely on family history, obviously. And then again, the family history, but also abnormal lab values. If you're seeing really high triglycerides, really high cholesterol, then that's your first thought is going to be some type of genetic connection. So weight management. This is another one. This was when I was teaching genetics, one of my favorite little lectures was when I was talking about, they were doing the twin studies, and they would look at adopted kids who were raised in families and look at their obesity rates versus their parents. And then they were looking at genetically biological kids being raised in the same families and their obesity rates. And they were seeing a higher correlation between your genetics. So they were seeing a lot of adopted kids having different weights than their parents, even though they're being fed the same foods and being taught the same level of activities and stuff. So that was when their first clue was that weight could be highly correlated to your genetics, which is no surprise because when I sit down to eat a meal with my husband, I can eat circles around that man. Like I'm way hungrier than he is, and it takes me forever to fill up. And so I, no surprise, also had some of the genes that related to high, appetite regulation, and that can be one of the big things. So if you do a lot of weight loss in your clinic, or if you're helping people with their weight loss, one of the triggers or one of the things you hear is somebody could say, oh, I eat twice as much as my friends. Well, that's probably because you're not feeling full quick enough. That message is not getting to your brain at the same rate as somebody else's. Or if somebody's like, I'm just hungry all the time, that's a big key. Sluggish metabolism. Here's another example. I remember going on a weight loss program with my roommate who was a guy, and he lost like 3 times as much weight as I did. So I never go on weight loss programs with men anymore. I know that's sexist to say, but I just don't do it. I'll just pick another lady, but I just quickly identified. I was like, okay, my metabolism works slower than other people's, and I don't respond to exercise like other people do. I typically will gain weight on that. That's not my problem. My problem and what I need to focus on is, my weight control. And these are the kind of things that you start to just figure out. And I did a lot of weight loss in private practice, and one of the first things I realized is that everybody struggles with weight for their own reason. My husband struggles with his weight because he doesn't move enough. That's not my problem. I move a lot, I eat a lot. It's just different for every single person. And again, that's when you can start cueing in and honing in on, okay, these are the things these people are saying. If they come into you and say, well, I'm overweight because I eat tons of sugar all day and I never move, it's probably, you can work on their diet first. But if you have a patient that says, I eat great, I exercise all the time, and I'm not losing weight, you're going to test their thyroid, and then you're going to go into genetic testing. So, diabetes, that's another thing. A lot of these genes that we were researching for weight loss, we were actually finding also correlated with an increased risk for type 2 diabetes. And it has a lot to do with sugar, insulin resistance, and metabolizing sugar. So if you have a patient that is diabetic or has diabetes in their family, they may have risk alleles there. Hypoglycemia, and I put that in there because that's a precursor to type 2 diabetes, so it's sort of same thing there, but that is that precursor also to insulin resistance. And insulin resistance has a lot to do with genetics. Depression, or genetics, also signs for nutritional markers. So this is another thing that's really interesting. Your ability to absorb and utilize nutrients, no surprise, has a huge genetics factor into that. So if you have a patient who you are giving them this supplement and their serum levels of whatever that nutrient is not going up, or you're struggling, it's not going up like it should, that would be a huge key. Other symptoms of just nutritional deficiencies in general also are depression. I mean, you need a lot of these, like B12, you need some of these cofactors to make these neurotransmitters. Signs of anemia, that's a big one. Your red blood cells, B12 and iron are both needed to make those red blood cells, and there's genetics that have to do with your absorption and utilization of those nutrients. So signs of anemia, fatigue, shortness of breath, pale skin, pale mucous membranes, tingling, swollen tongue, craving of pica. Has anybody ever had a patient with that? Just interesting things like craving ice. If you hear a patient is just eating ice, chewing ice, that is a big indicator of some type of anemia going on. And then just blood levels of these nutrients, like B12. That's when I order routine labs, that is a part of my routine lab testing is B12. Dry skin and hair, brittle nails, brittle bones. So mood, other aspects too, neurotransmitters and neurotransmitter levels, and I think this is, you can see this in any conversation that you have with anybody. You can see there's certain people who are just naturally peppy or naturally down, and that is that change in neurotransmitter levels, and there's a huge basis in genetics for that. So look at their mood. Are they sensitive to stress? Are they a type of person who has a stressful event and then they hold on to that for the rest of their life? That has a lot to do with dopamine levels. Anxiety, depression, difficulty sleeping, ADD, ADHD, low energy. These are all symptoms of neurotransmitter imbalances which can have a basis in genetics. So gene groups. We've found some of the most well-researched medically relevant genes can almost be grouped into it, and that's what we spend a lot of time at Kashi doing is trying to make those connections and group those genes together so you don't have to, and that's why our reports look the way they do. Some of the groups that we found, cardiovascular, we found several genes that all relate to and affect the health, cardiovascular health of patients, weight management, mood, nutritional deficiencies. Those are some major groups that we'll talk about today. So here's a quick rundown of the cardiovascular group. There are some of the most well-researched genes that affect the cardiovascular system are 9p21, and that actually has been shown to affect your propensity towards forming plaques, atherosclerosis. And some people with a risk factor are more likely to or have more plaque formation at a younger age. Well, there's clotting factors. Factor 2 and 5 will increase your ability to clot. So this is kind of one of those patients where they say, oh, my dad had a stroke in his 30s or 40s or 50s or something to that effect. If you hear something like that, I would absolutely test somebody's genetics for the factors. MTHFR, high homocysteine levels has a huge effect. That's vascular inflammation. It has a huge effect on the cardiovascular system. We'll talk about each one of these genes in greater detail. So ApoE affects cholesterol levels. You can have, this is going to be one of those patients that has high cholesterol levels, and that I was saying that it would probably look sort of almost on a genetic level, or high cholesterol levels at an early age. that would tell me to check their ApoE. And if you have a patient with late Alzheimer's disease, late onset Alzheimer's, not early onset. Early onset is also genetic, but that is a more rare genetic condition that is separate from regular SNP testing and that kind of stuff. Think ApoE. eNOS and AGT both affect vasodilation. So this might be, if you're talking about a patient who has high blood pressure that you just can't get down, or has high blood pressure at an early age, I would test for these genes right here. And then SLCO1B1, I love these names. I don't know who comes up with these names. If I was allowed to name them, they would be like really flashy and easy to memorize. I'm just gonna say that. This has to do with statin metabolism. So if you have a patient that is not responding to their statin drugs, like it is not helping their cholesterol level, it might not be because they have so astronomically high cholesterol levels. It might just be that they metabolize that drug differently. And drug metabolism, there's also testing you can do on a larger scale to see how a person metabolizes all sorts of drugs. And a lot of physicians who prescribe a lot of drugs will do that.
This is also associated with the high risk of rhabdomyolysis or not?
This one?
Yeah.
I don't know about that association. The SLCO1B1 is associated
I don't know.
Yeah.
I'm asking.
I haven't heard that.
What was it associated
with high
Rhabdomyolysis.
rhabdomyolysis?
You just studied?
Yeah, no, I haven't heard that one. Yeah, good question. Weight management. So this is interesting because a lot of these genes overlap. They're each different individually, but a lot of these will overlap in their symptom picture. FTO is a big one. This one is one of the most well-researched genes of obesity. It has to do with appetite regulation and cravings. So it will increase your cravings for food. You'll feel hungry all the time. And what do you do when you feel hungry all the time? You crave high-calorie foods. And if you can eat, you eat. So the person is going to be craving high-calorie foods, their fats, their sugars, and they're going to be hungry all the time. And then when they do sit down to eat, they're not going to feel full as fast because that signal that goes from your stomach to your brain is just not as powerful in these people. DRD2, when combined with FTO, there's a risk allele in this gene that if you have a risk allele in this one and that one together, it's even more intensified because DRD2 has to do with dopamine receptors. And if you guys remember, dopamine is that pleasure response. And definitely you're getting that pleasure response when you eat high-calorie foods. FABP2 has a lot to do with fat absorption. These patients will actually absorb fats more readily from their diet. So when they eat a fatty meal, they're getting more fat from that than somebody who doesn't have a risk allele in this gene. You also have ADRB2, and that has to do with carbohydrate metabolism, breaking down carbohydrates. And then also they've found in research that these patients will not lose as much weight from exercise. And then SH2B1 is a very interesting one. I think is one of my favorites, but I just think it's incredibly fascinating because this is people with this risk allele are more likely to be leptin and insulin resistant, meaning they are more likely to not respond to the messages of insulin. So they're going to keep that sugar in the blood and not bring it into the cell as readily or as easily as somebody without this risk allele. And the same thing for leptin. Leptin is that hormone that tells you you're full. They're resistant to that message. These genes kind of all fall into that group. Nutritional deficiencies. You can see there's genes in folate metabolism that become deficient and you're not utilizing that folate. You're not utilizing folic acid from your diet. You have to get it from folate. There are several genes, VDR, GC, NADSYN1, CYP2R1. These are all genes that have to do with vitamin D serum, maintaining a healthy vitamin D serum level. And they do it in different ways. One, CYP2R1 is involved in vitamin D metabolism. It takes the breakdown product of vitamin D and it takes it to one of those last final steps to make it into the active form. Another one transports vitamin D around the body. Another one can actually convert the precursor of vitamin D into cholesterol favorably, stealing the precursor from vitamin D. And then you also have one that deals with vitamin D receptors, relaying that message. So it's really interesting how the genetics can play together. It's me stating the obvious, but one defect in one of these genes is one thing, but to have a risk allele in almost all of them, like I do, then you're really gonna say, hey, I need to be checking my serum vitamin D levels a lot and taking supplement. I take my vitamin D on a regular basis anyways, because I also avoid the sun. That's another story. We have metabolism of vitamin A over here. That obviously when you can encode for these enzymes that are a part of those metabolism pathways for a lot of different vitamins. And absorption. Genetics affects your ability to absorb nutrients. Mood. There's a lot of genetics involved in regulating and maintaining a healthy mood. It's really kind of the just subtle differences between every single person. One of the major genes that's involved in mood regulation is the COMT enzyme because it helps break down dopamine. If it's slow, you can have really high dopamine levels and your receptors, your dopamine receptors become insensitive, just like it would with insulin. If it's really low, your dopamine levels are low, you're not getting enough of that dopamine stimulation. It's just like with most things in life, it's about balance. MTHFR can also have an effect on your levels, your neurotransmitter levels, because it produces byproducts like SAMe and its metabolism that are very important for brain function. Also, the FUTS2 or FUT2, that has to do with B12 absorption. Well, B12 affects neurotransmitter production. GC, and then you have the vitamins or the genetics that are involved in vitamin D. And we know that vitamin D is really important for overall health and mood. Seasonal affective disorder. So the interplay of genes. I just kind of want to give a quick example of how genes can affect each other because they're affecting products that are then come down the line to affect another product. So an example is MTHFR. You have two risk alleles here, and they affect the ability of this enzyme to help methylate folate and add into the folate cycle, which Dr. Angela or Dr. Knapp will be talking about in great length. So I'm not going to bore you with those details. But one of the things that it does is it creates SAMe, and we'll kind of go into that. So some of the symptoms that are related to an MTHFR, like having an MTHFR risk allele, can be across the board, really. You can have developmental defects like spina bifida, you can have heart disease, you can have glaucoma, and you can have mood disorders. Recurring pregnancy loss. It really has a widespread effect. The COMT gene, this enzyme, it encodes for an enzyme that breaks down catecholamines. Well, one of the things that it needs to do that, to work, is SAMe. So are you starting to see the connection here? MTHFR is helping make SAMe, and COMT needs SAMe. So what do you think is going to happen if you have a problem with MTHFR? If it's not producing enough SAMe, and then on top of that, you have a slow COMT enzyme. You're compounding that effect. There's an interplay there. And one of these genotypes does have causes a decreased functioning enzyme. So an example would be if I saw a patient with 2 copies of the C677T gene for the MTHFR, and then they had a MET genotype, I would really want to know how their mood was. I would really want to work on that if it wasn't good. And that's kind of that use of genetics to see the bigger picture. This is the part that I think as when I'm doing the clinical consultations, it can be a little bit mind-boggling for some of the physicians because it's a lot of like just memorization of these pathways and making these connections and stuff. But I do think it's kind of the wave of the future, like where we're moving towards. So this kind of outlines that and talks about how these can affect stress levels and your ability to respond to stress. So the phenotype val is going to have higher enzyme activity, lower dopamine levels. And then this here talks about the interplay with the creation of SAMe and the use of SAMe by MTHFR. And I kind of just outline this just in case anybody likes to see, you can have a product, a starting molecule, and an end product, and then these unsung heroes in the middle, the enzymes that take one substrate to the next. Well, if you have a defect in this one and this one, then you're going to have a huge problem creating that product. Another example is CYP1A1. This enzyme, it helps break down estrogen. And what it does is it takes estrogen and makes it into a compound, or it's called E2, 2-OH-E1 or E2. This is a metabolite of estrogen that is pro-cancer. It can stimulate cancer. And you don't want this metabolite. You want it to be taken by the next enzyme in the pathway and turned into the next metabolite, which is actually anti-cancer, 2-MeO. So you want those two enzymes to be working in concert together. So again, what happens if you have a fast CYP1A1 and a slow COMT? You're going to have a buildup of that cancer-causing intermediate. And these are things you kind of want to look at and keep in mind. This can show you where they all are. I think I have little arrows. So here's the first step where you're taking estradiol, and then you're creating this intermediate, and then COMT is taking it to the next metabolite, which is actually anti-cancer and protective against cancer. So making those connections. So you really want to look at all of these together to kind of start to put the pieces together. And I think as genetic testing gets more and more popular, this will become secondhand. So in this case study here, they actually showed that catechol-estrogens were higher in certain COMT genotypes, illustrating that this actually has it's not just a chemical pathway, it's shown in research to create that intermediate. And that the MET genotype had decreased formation of this protective estrogen. So using this as a whole to treat your person, remember to teach your patient, remember that many proteins work together in concert to affect health, that there are certain signs and symptoms that are more key to when you would want to order genetic testing. And then they can give you tips for picking a very precise treatment plan. Say, for instance, you have an enzyme that is not functioning, it's not creating the next product. Well, if you can supplement that next product and bypass that enzyme that's not functioning properly, it's a quick and easy treatment that people are going to see a huge benefit from immediately. So understanding those biochemical pathways can really come in handy. And then you can use genetic testing to pair with different identifying predispositions. And mostly, in my opinion, some of the most important uses is to identify risk factors and to monitor and surveil your patients early on. Genetics is where we come from. It is deeply natural to want to know.